anyway, we wanted to do this just to kind of answer some questions about post-op care for our cabbages once they reach the INC, just so that we can have, you know, consistent care and everybody be aware of the goals that we're trying to meet every day. So I'll start off by saying this is Mandy and Hannah. They both work in surgical ICU, and so they may be helping, you know, just kind of talk about the things that they do in SICU to give everybody kind of a broad picture of what's happening with these patients, okay? All right, so we utilize a cabbage valve pathway. We're trying to get a little, come on in, trying to get a little bit more routine and better about using an actual pathway. And the reason why we do that is to, number one, improve patient care.
Hey, I'm sorry.
That's okay. I'm just glad everybody's here. Come on in.
Is there another, there's still another chair over there, buddy.
I'll do it. You didn't miss much. I was just telling everybody who I was. This is Mandy and Hannah. They're from SICU, so they're gonna kind of give you guys some insight on what happens there. So back to utilizing a cabbage valve pathway. Basically, we are trying to get a little bit better with that so that everybody knows what to expect. It improves patient care, utilization of resources, which they don't let me handle the money, but I do get the pressure when people are here too long, so I know that, you know, they need to be here just long enough to receive the care that they need, but not much longer after that, which goes also into cost containment, and it increases patient satisfaction. And that's a big deal because if people know what to expect, then they're least likely to be upset. You know, if you're coming at them telling them to do certain things and they're not expecting it. Despite us having, you know, like the pre-op teaching and blah, 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 I think some people still kind of come in with the expectation of having no pain, and then they come in with the expectation of having the surgery and then kind of just laying around and chilling for the next few days. So then when we start telling them, okay, you gotta get up, you gotta get moving, you gotta get walking, they get upset, and you know, that's when we run into some problems. So I think if everybody kind of knows what to expect for the day, then it makes things run a little bit more smoothly. So here's just the definition, or what we know is cabbage, coronary artery bypass grafting. I did not cite my sources, so I apologize. Don't call the police on me. So cabbage is commonly known as a heart bypass surgery. And what I added on my other one is that in layman's terms, people say open heart surgery, even though we don't enter the heart unless we're doing a valve. So heart bypass surgery procedure where we correct narrow or blockages of the arteries that provide oxygen and blood muscles to the heart. So I'll just show you kind of what I tell my patients if I'm approaching them about having surgery. And I think I kind of got this from Dr. Osborne. He uses his fist, and he says, this is your heart. You have 3 main vessels that feed your heart. And he kind of does this little thing. And he says, if these represent the blockages, we build bridges over the blockages so that you can get the blood and the oxygen that you need to your heart. And I think when you use some type of visual, it just really kind of hammers in why they need the surgery. Because if you've got all 3 vessels blocked, you need surgery. So if we all kind of say the same type thing, then it looks and sounds like we know what we're doing, right? So let's, anytime you can kind of just reinforce things, it makes things a little bit easier. So just a little bit about a valve and aortic valve and mitral valves. In these procedures, we actually do go into the heart to replace the valve. An aortic valve can either be tissue or mechanical. We do TAVRs as well, but that's outside of this slide. And then with the mitral valves, we use an artificial valve that's usually mechanical. And so these patients are the ones that on post-op day 3 or 4, we need to be talking about what kind of blood thinner we're going to be putting them on. So it's real important that on post-op day 4, those pacing wires come out, right? So, and that's why. So when they come in, we've already talked to them. They usually have already done their labs. They do a pass appointment. Is that on here somewhere? Yeah. So they do a pass appointment, typically like a week before their surgery if they're an outpatient person. So they come in, they get some labs done, they get their PFTs done, their carotids, they do that all as a pass appointment, like I said, about a week before time. And so the day of surgery, all they have to do is kind of come in, check in. If there's some labs that we need to follow up on, then we order those, anesthesia, and the surgeon goes see the patient, and then we roll. So when they go to the operating room, in their 4 to 5 hours, the first hour, just in case patients ask you, the first hour we're usually just doing the positioning, you know, anesthesia's doing the intubating, we're putting all the lines in. Hour 2 to 3 is when we're harvesting the vein if we have to do that. And then we do bypass surgery. Hour 4 is usually coming off the pump and testing all the grafts and closing and preparing to go to the ICU. Any questions about that? This is an actual surgery that we did. I'm kidding. But anyway, this is kind of what it looks like if you're behind the curtain and you're looking over. And this is just the lines that they use to bypass and the blood leaves the heart, goes into the heart-lung machine and circulates there. Okay, so the day or right after surgery, they go straight to surgical ICU. I think some people still think that our open heart patients go to PACU. They do not. They go right from the OR table directly to surgical ICU. They admit them. It's from table to table. So. Do you want to talk a little bit about the admission of a patient into surgical ICU and how they arrive and what needs to be done?
Sure. I thought I was just coming for support. Normally, when we get a fresh heart, it's all hands on deck. Everybody has their tasks. The primary nurse is normally the one up by the anesthesiologist, untangling the cluster, that's your lines, getting them on our monitor. Because right now our monitors are different than the ORs, so they'll come on theirs most of the time, and so we're changing out, hooking up, making sure how's our blood pressure, how's our heart rate, making sure our vitals are kind of stable.
Do we have a blood pressure?
Do we have a blood pressure? Looking at what drips they come on. Then you have a nurse, checking pulses, making sure we got all of our pulses, someone hooking up your chest tube. You have someone dragging and dropping, someone needs to call x-ray, let them know we're ready for our stat chest x-ray. We get a EKG post-op, you're doing lab work post-op. It's pretty much several people, hands on deck. You'll do an ABG first off, post-op, you'll hand to the perfusionist, and they'll normally run your first ABG, and it'll have your electrolytes on it, your H&H, all the normal things a blood gas will have on it. Making sure kind of get them stabilized in that first several minutes, first 20 minutes, making sure you're okay, then kind of going from there.
So there's a lot.
It's a lot when they first get to us.
A lot of moving parts there. And when she says all hands on deck, we used to have this system, So we had nurse 1, nurse 2, nurse 3, and we needed all 3 people to know what their job was because you can't concentrate on everything. So a lot of these patients, they arrive and they appear to be stable at first, and then when whatever they push wears off, then the bottom can fall out. So you just have to be really watching the monitor, watching your patient. They're usually asleep 2 to 3 hours preferably while we're trying to get them settled in. So they come out with a swan, the art line. We've got hooking up the chest tube, the mediastinal chest tube, the JP drains, and so there's a lot going on with that. And the more drips, the more complicated it can get. So I've offered a few people, and everybody is open, can do this. But when we have a post-op CABG, if you guys have a minute and I want me to take you down to SICU just so you can kind of see what's going on, I'd love to do that for anybody who wants to do that. Kind of just gives you a little insight. This is kind of what they look like. This is not actually a patient. I probably should. I got this off the internet. But so they're on the vent here, of course. I think that's what's happening. And so this is like the swan, and it gives us all the hemodynamic numbers. And we try to shoot a set like within the first 20 minutes or so to kind of get a baseline. and to figure out what we need to do for the patients just to get to optimize them. And so routinely, if they're not on many drips and they're doing really good, we get these hemodynamics every 4 hours, and then more often depending on what drips they're on and what they need. Okay, so Hannah, do you wanna read about what goals we have on post-op day
Sure.
1 at SICU?
So post-op day 1, we want them to wake up, get out of bed to chair, really important to mobilize them. They hate doing it, but they always feel better when they do. Want to sit up and eat breakfast, very strict eyes and nose, we want to make sure nothing changes, nothing's starting to bleed, making sure their urine output's great. IS, sternal precautions, we put a big, I call it a bear hugger, but it's basically like a big hard sternal
Heart
heart hugger, yeah. Obviously stable labs and chest x-ray. When they get back to bed, we wanna discontinue their Swan-Ganz and introducer if we're able, DC their art line fully, and then get them back to bed, or get back to chair for lunch and transfer.
So this is like if everything goes straightforward, as planned. We, as far as the heart hugger, like she said, that's when they initially start, reinforcing those, sternal precautions. Cause we've had people that have, not followed the plan and had to go back to surgery and have plating, and then it just turns into a big mess. Because once the sternum falls apart, and it could be 1 or 2 wires, they have to go back, they have to have, debridements, and then ultimately, if we can't get, they develop an infection, we can't get it under control, we have to take the sternum out and do like a flap surgery. So it's really, really important that we stress that as often as we can. I want them to wake up and think about it and go to sleep and dream about it. That and incentive spirometer are big, big deals. Now, so out of bed to chair. Typically we like for the nurses in SICU to put the TED hose on before they get up. That's just, part of it, and that way it's done. Sometimes they still have their ACE wrap on, and people will leave those on. Once they get to E300, if you get a patient that has an ACE wrap and a TED hose, you probably can go ahead and take that ACE wrap off. I prefer, as long as it's been 24 hours since cut time and dressing time, I prefer them have the TED hose on than the ACE wrap. Oh, and another thing about the ACE wrap, make sure they're not too tight. Make sure your TED hose are not too tight. We've had some pressure or some shearing injuries from the TED hose that were too tight, or they weren't readjusted, or they weren't ever taken off, and they formed these really deep shearing injuries. So
And that's starts with SI too, so she's talking to us too.
okay, so this is what a nice little patient somebody's nurse looks like, getting out of the bed. So on post-op day 1, when you guys get them, they've been through a lot, trust me, and I don't know if you've been to surgical ICU, but it's an open unit. I think some of these patients have PTSD because they hear a lot, they see a lot, there's a lot going on down there. So when they get here, they do probably just want to rest, and that's okay, for a certain amount of time. But if you get them up there and it's, and they've been in ICU all day, you wanna go ahead and walk them, whenever you can. So that day, we just wanna establish rapport and then just kind of explain to them what's gonna happen so they don't get angry when you come in to do what you're supposed to do. As far as, assessments, you wanna assess from head to toe, all the incisions, drains, make sure their TED hose are on, and make sure that you're still doing some type of neurovascular assessment, because these patients can stroke at any time, so wanna make sure that we stay ahead of the game there. And out of bed for all meals is what we would prefer. We don't really want them eating in the bed. It kind of makes them feel like they don't need to get up. So if we can establish, okay, you've gotta be out of bed for all meals, they kind of can judge when they're gonna have to be out of bed. Post-op day 1, ambulate in the room. If they're superstars, go ahead and throw them out in the hallway. If not, just have them get used to, getting around in the room. And then pain management is a big deal. So we don't wanna over-sedate them with pain management, but we know that if we don't manage their pain, they're not gonna deep breathe, they're not gonna get up, and they're gonna be mean to us. So let's give them their pain medicine. 2 and 3. Does anyone from E3 wanna tell me what they do on days 2 and 3? What they think the goals are? Michelle?
At least twice in the halls.
Yeah.
Ambulating, I mean, just depending on the patient, but at least 2 times in the hall. I mean, if, like I said, if they're superstars,
Yeah,
then
let 'em
they
go.
get after it, but, yeah, at least twice.
Twice in the halls, and then, cardiac rehab, we'll come and see them, preferably cardiac rehab. OT and PT are good for our patients that, are slow movers and are extremely weak. The only problem with that is I don't think they see them on the weekends, so then it's up to the nurse to make sure that they're getting up and walking and doing everything. So incentives barometer, of course, it's very, very important. And so you'll see on my note, I'll put pulmonary toilet. It's kind of a joke because I used to see that on Dr. Akbon's note when I was still a nurse. And I'm like, what the heck is a pulmonary toilet? So I put that on there, but basically it just means all the things that are gonna help their lungs expand, you know, so incentives barometer. If you've got one that's lagging behind and you think they need a flutter valve and some cough medicine, by all means, just shoot me a text or just put it in. I don't care, that's fine. If you've got one that needs breathing treatments, let me know. I'll put it in. Like, whatever we need to do, don't be afraid to ask, don't be afraid to mention, just let me know and we'll get it figured out. Nutrition's a big thing. They don't have an appetite. A lot of them, the food doesn't taste the same or it doesn't taste good. Not because of what's going on in the kitchen, but because after anesthesia, sometimes their taste buds change. So we've gotta make sure that they are on, some supplements if we need them. Ambulate in the hall. And then documenting I's and O's is very important because that's how we determine when we're gonna DC those drains. So if there's no documentation, we either assume that, there's no output or, it's like, what's going on? Because we wanna get those drains out as soon as we can. TED hose, sternal precautions. Post-op day 2 and 3, I guess. Okay, here we are walking patients in the hall.
Sorry.
So on day 4, we're gonna continue with the skin assessment, wound assessment, and dressing changes. Make sure they're ambulating. DCing pacing wires is very important on post-op day 4. I know when I put the orders in, I try to make sure that it's there, but if it's not there, that's just kind of standard. Just know that we want those pacing wires out on post-op day 4, as long as nobody has started any blood thinners before. And if you're uncomfortable putting that order in, just shoot me a text or whatever, and we'll get it figured out. But we prefer post-op day 4 to be the day that we DC pacing wires. If we're going to start some anticoagulants, we can take them out earlier if they haven't used them. We just need to all kind of communicate and let each other know what's going on. We start DC